Everybody. Hello, everybody. It's a great pleasure and big honor for all of us in the University of Crete and in the Radiation Oncology, the Greek Radiation Oncology Society, the visit of our distinguished professors from the University of Pennsylvania, Professor Neha Vapiwala and Professor John Plastaras. It's a great honor for us. Thank you for so much, because we know that it's your holiday. Our Professor Dimitrios Mavroudis of Medical Oncology. Well, okay, and then our President of Greek Radiation Oncology, George Koukourakis. A brief welcome.
Thank you.
Dear colleagues, dear guests, it is both an honor and a great pleasure to welcome you today on behalf of the Hellenic Society of Radiation Oncology to this important scientific event organized by the Departments of Medical and Radiation Oncology of the University General Hospital of Heraklion, Crete, PaGNI. We are especially delighted to welcome two distinguished leaders in the field of radiation oncology from the University of Pennsylvania. As you already heard, Dr. Neha Vapiwala, Professor and Vice Chair of Education, ASTRO President-elect, and Dr. John Plastaras, Professor and Vice Chair of Strategic Clinical Research, Chief of Radiation Oncology and Proton Therapy at Penn Presbyterian Medical Center. Their contributions to the advancement of radiation oncology and their commitment to education and research continue to inspire the global oncology community. Today's program offers us the opportunity to gain valuable insights into cutting-edge developments in radiation for both solid tumors and hematologic malignancies, including the integration of CAR T-cell therapy, topics of critical relevance to our daily practice. I congratulate our colleague, Professor Sophia Angelaki, Dimitrios Mavroudis, and of course, my colleague and good friend of mine, Maria Tolia, for their initiative and leadership in organizing this session. Of course, I thank you all of you for joining us in what promises to be a rich and thought-provoking discussion. I hope to future co-organization of such interesting scientific meetings with our guests. Thank you very much for the opportunity.
Thank you so much, Dr. George Koukourakis. A brief welcome also from our Professor Elko Debre, that is Professor of Surgical Oncology in PaGNI, in University Hospital, Faculty of Medicine, University Hospital of Heraklion in Crete. Thank you so much. Thank you so much. Very interesting topics. Thank you so much for the selections, insightful topics. Thank you so much.
First, I just want to say I am so incredibly touched by this warm welcome. I love everything about your country. I love everything about the fact that you are so, not only excited and welcoming to see us, but also, true colleagues in every sense of the word. And I hope this is just the beginning of many conversations and discussions that we can all have together. So it means a lot to us that you opened up your department and made all this time for us. So we promised to keep it not too long, and we thought we would just focus on very specific topics. And thank you again for the incredibly kind words at the start. So I thought we would just review briefly for those of you that are familiar with locally advanced prostate cancer. It is in the United States one of the most common diagnoses that we make in the cancer world, increasing in incidence, but also, again, more importantly, within prostate cancer, increasing percentage of patients who present with locally advanced disease. and in many cases, metastatic disease, as we are more and more discovering through the use of PET scans. Do you have a lot of access to PET scans
Yes,
here?
yes.
Okay, excellent. So you know what I mean when I say that an increasing number of patients will be found with micrometastatic disease. So it is becoming more and more a place for radiation oncologists to contribute along with our colleagues in medical oncology and surgical oncology in the management of these patients. So I thought we'd just do a brief review of some of the more exciting things that are happening and where we are in the use of radiation in these patients. As mentioned, I have no conflicts of interest. So one of the questions that often comes up, and we talk about, again, radiotherapy dose, and the question is always more versus less. And what do I mean by that? We, of course, have our standard, moderate, and ultra hypofractionated regimens. And for the non-radiation oncologists in the room, this typically refers to ranges of 1.8 to 2, 2.8 to 3.5, and over 5 gray, respectively. So as we think about the world of, oh, sorry, my animation is not behaving. Oh, apologize. I'm not sure why that's not showing up. Oh, there we go. So dose-escalated external beam radiation therapy has long been what we have done in the world of prostate cancer, typically around 80 gray, delivered with standard fractionation. In a presentation at ASCO in 2024 and subsequently published in JCO, Heraklion and colleagues actually found for the first time that dose-escalated external beam radiotherapy improves not only biochemical progression-free and distant metastasis-free survivals, but also improved progression-free survival, cancer-specific, and overall survivals when given in combination with long-term androgen deprivation therapy. This became headline because up until this moment, all of the dose escalation studies in radiotherapy thus far did not demonstrate an overall survival benefit when used in combination with long-term androgen deprivation therapy compared to standard dose radiation. So this became some data that now suggested, okay, perhaps in fact, there is more than just a biochemical benefit to dose escalation. But the real question becomes, how do we deliver this in less time? Our patients are busy. There are, in many cases, resource limitations to how many patients we can treat. We want patients to be able to complete their treatment. We know that patients who do not complete their scheduled treatment, have treatment interruptions, or do not show up for treatment, are going to have worse outcomes. So it benefits us all in the radiation therapy world to offer convenience, if possible, without compromising our outcomes. So the PC Study 5 by our colleagues in Canada looked at high-risk prostate cancer and was a non-inferiority phase 3 study looking at dose-escalated external beam radiation and long-term androgen deprivation therapy using standard fractionation to treat the prostate and the pelvic lymph nodes in these high-risk patients versus moderate hypofractionation using concomitant dose escalation and still treating the lymph nodes. And this was one of the studies demonstrating that moderate hypofractionation in the high-risk population is both safe and viable. Again, taking advantage of the radiobiological principle of the low alpha-beta ratio of prostate cancer cells, which suggests that they are more sensitive to the size of the fraction compared to many other solid tumors. And furthermore, compared to the normal tissues, which typically have a high alpha-beta, as shown here. So with that sensitivity, increased sensitivity to dose size, we are taking advantage and hopefully making this more convenient for patients. But can we go even faster than moderate hypofractionation? This is where we look at the concept of therapeutic index, the idea of escalating target dose, sparing normal tissue, using tight margins and steep dose gradients. Can we do this with stereotactic body radiation therapy with the most ultra hypofractionation? Remember, that was 5 gray per fraction or higher. And can it be done safely? Just because you can give more dose faster does not mean it can be done safely. So here, again, taking advantage of the alpha beta ratio, we have the SHARP consortium. This was a collaboration of 7 institutions combining their phase 2 trial data and their registries to see if in high-risk prostate cancer patients, could you deliver stereotactic treatments, so 5 fractions or less, and still have favorable toxicity and efficacy. And that was reported as early as 2021 in their initial studies. So again, establishing that in high-risk prostate cancer, we do believe that SBRT plays a role and that it can be used for elective nodal radiation as well. 1 in 5 of these patients did in fact have elective nodal radiation using this fractionation, and almost 3/4 received androgen deprivation therapy for a median of 9 months. This established then in our national, and I apologize if this is in the way. I don't know how to minimize that. Our National Comprehensive Cancer Network, which is in the United States, a body that determines treatment guidelines, as a direct result of these data, did add for the first time that SBRT is now acceptable treatment of primary prostate cancer across all risk groups for local, regional, as well as for treatment of distant metastases. However, they very importantly note it must be in practices with the appropriate technology and expertise. And this is because of, again, the high resource involvement in first establishing an SBRT program, the technical skills that are needed, as well as the planning and delivery expertise that's needed. So with that established, now it becomes another question. Is external beam the only way that we can deliver high doses? And this is where the age-old technique of brachytherapy still remains in many parts of the world the most efficient and economical way to deliver this treatment, if especially you do not have the equipment or expertise for stereotactic body radiation therapy. So here we have direct and efficient dose escalation directly to the gland, no better way to give more radiotherapy in less time. And what we're finding now, both through the Ascend RT update, which is our Canadian colleagues looking at almost 400 intermediate and high-risk patients with prostate cancer who received androgen deprivation therapy for a year, pelvic radiotherapy for 46 gray, and they received prostate boost via both external beam as well as through a low-dose rate iodine 125 technique delivering 115 gray. And although there was some worse late genitourinary toxicity that was reported, ultimately, at 6.5-year median follow-up, the low-dose rate technique improved biochemical control. And by 10 years of median follow-up, overall survival and distant metastasis were comparable across the two. So you have a much more efficient way of delivering this technique through brachytherapy, and it does not yield worse outcomes. And if anything, it improved biochemical control, albeit with potential for worse late GU toxicity. Now, one caveat about the worse late GU toxicity, again, in centers with low dose rate brachytherapy expertise, in high volume centers, in the hands of people who do these cases often, usually those GU toxicity rates are lower. And when you have a large trial such as this with many different centers, it's thought that sometimes the toxicity rates are worse than if you specialize in this particular technique. There's also data from Canada, a phase 3 trial in looking at high dose rate brachytherapy boost. This was 116, again, high risk prostate cancer patients. In this case, 3 years of androgen deprivation therapy, but no pelvic radiotherapy. So again, clinically node negative patients. And here they looked at external beam radiotherapy alone, given in a moderately hypofractionated regimen of 55 gray and 2.75. Again, very common in the UK and Canada, versus a lower dose of external beam and 2 fractions of high dose rate brachytherapy, 8.5 gray times 2. And at a median follow-up of 131 months, the high dose rate boost, in fact, improved the 12-year relapse-free survival by 21%. Overall survival difference was comparable, perhaps with longer follow-up, maybe the curves will separate. But perhaps most importantly, the severe late urinary and bowel events and urethral stricture rates were comparable. And so the field in general does have, in our part of the world, in the United States, a preference for high-dose rate brachytherapy. We are almost entirely doing high-dose rate brachytherapy, but there are still centers that use low-dose rate. And again, they are centers of excellence with very high volume. And that is, for many patients, a preferred way to deliver the dose efficiently. So as we move on then and think about more creative ways to boost, there is now, thanks to multiparametric imaging and thanks to the beauty of PSMA PET, both PET CT as well as PET MRI, the potential to dose escalate what we call dominant intraprostatic lesions, or DIL for short. The feeling now is you know where the majority of the cells are in those patients who have identified dominant intraprostatic lesions that can clearly be isolated. There are many reasons to believe higher dose delivered there is really what you want, rather than a general boost. And in doing so, perhaps you can spare urethral toxicity, particularly for DILs that are nicely localized. So we now have the FLAME trial, focal lesion ablative microboost in prostate cancer. This study has had quite the splash. 571 patients, again, intermediate and high risk, no nodal radiotherapy, so clinically node negative. Almost 2/3 received androgen deprivation therapy up front. And all of these patients had dominant intraprostatic lesions identified by MRI. And what the fractionation did was 77 in 2.2 gray, so nothing too dramatic, with or without the use of a integrated boost with external beam. So given simultaneously up to as high as 95 gray in fractions up to 2.7 gray. So they took baby steps. They didn't want to go too fast. And what they found, and again, I'm going to just move this around. Can't read my own slides, is decreased local failure, which is really what the primary endpoint was. And then the suggestion of decreased regional and distant failure. I put that in quotes because they were not powered to look at this, and this was not part of their statistical analysis. But if you look at the proportion with disease-free survival, you can see clearly at 72 months median follow-up that the focal boost clearly separated compared to the standard dose delivery. The reason this is particularly important, we would expect local failure to be improved. We, as radiation oncologists, think of ourselves as local doctors. We're so focused on local disease. But there are prostate cancer patients in whom the seeding from the dominant intraprostatic lesions to potential future micromets is very well established in the basic science literature. I don't have time to show all of that work now, but Gundam and colleagues established actually quite a while ago that you can self-seed. And if you can reduce the burden of disease where it starts in prostate cancer, you really can make a difference in future metastatic risk. And so there are reasons to believe in clinically node negative, radiographically node negative patients who might have otherwise in the future had persistent disease in the prostate that would later spread to the nodes and to the distant sites, that by delivering higher dose with this FLAME technique, you are providing much better ablation of local tumor, and therefore, over the long run, providing a benefit in terms of regional and distant recurrence. And so again, this just argues the importance of local treatment, not just for local control, but what it holds for the patient long-term. And with prostate cancer patients, we must always think long-term. 5 years is really the shortest we really want to think about follow-up for most of the survival outcomes. So many of these patients will go on 10, 15 years and live long enough to recur. So the FLAME study has really now revolutionized our idea of doing microboosts. What about SBRT for microboosts? Instead of just doing standard external beam, getting back to the variety of little small phase 2 studies. Now, these are going to be smaller studies with much shorter follow-up, but they are exploratory, and they are suggesting to us as radiation oncologists creative ways for us to get those treatments done and done in the shortest period of time. This is a small study of 30 patients, 2/3 of whom were high-risk prostate cancer. 35 gray delivered SBRT, 5 fractions, and roughly 50 gray delivered to the dominant intraprostatic lesion, all using SBRT technique, while simultaneously treating the lymph nodes in 5 fractions. Note that this was given once a week. Again, toxicity concerns in this small phase 2 trial. Hypoflame, 100 patients, 75% high risk. Again, a lot of these are still reporting out, and they're accumulating patients. Here, median 44.6 to the dominant intraprostatic lesion using SBRT technique. So far, early results, 1.5 years. No acute grade 3 or higher toxicity, promising. The SPARK study, only 8 patients. This is using CyberKnife. I don't know if you have the CyberKnife machine here. It is an Electa machine, I think, made by Electa. Oh, I'm sorry, Accuray. That's right. Accuray CyberKnife. I don't know why I said Electa. Accuray, that's right. I have Electa on the brain from seeing your machine. Yes. Accuray makes CyberKnife. We do not have a CyberKnife in our facility, but some centers do. 6 degrees of freedom, robotic arm. And here it was used to deliver, again, about 47.5 gray. Interim safety analysis at almost 5 years. Modest acute and late grade 2 or higher toxicity, and thus far, no biochemical failures. So more and more centers are using whatever SBRT technique they have to try and deliver the flame type radiation, but instead of using brachytherapy or external beam, they're doing it entirely with SBRT. And then our colleague, Dr. Zamboglu, in Germany, and colleagues are actually launching this study, hypofocal SBRT, which they've launched. This is incorporating PET info. So rather than MRI, which is what all the other studies used, they are using PET to define the intraprostatic lesion. They found that on average, it increased the median volume that was being defined for dose escalation compared to CT or MRI alone. So you have 2 arms here. The control arm is entirely with moderately hyperfractionated radiation therapy using moderate hyperfractionation, all external beam, and the experimental arm is all SBRT. Prostate and seminal vesicles, 30 gray. Prostate itself, 35 gray, coming off the seminal vesicles, and then a boost anywhere from 40 to 42 gray, all defined purely on PSMA PET. And what they found, not only is the dose escalation feasible using the PET in all of the Arm A patients, but it was feasible in 23 of the Arm B patients. And again, this study is still accumulating patients, so we have data that are forthcoming. But what they found is they've gone up to 19 gray in a single fraction. So again, pushing the envelope after you've already delivered 35 gray to the prostate. So really seeing so far at just 6-month follow-up as of this report, that was, again, the 2021 was when they first described the study. Since then, they have presented an abstract form, no grade 3 toxicities observed. And this is actually the first prospective data we have supporting feasibility of PET to define the focal lesion and to deliver dose-escalated radiotherapy. Thus far, 6-month follow-up that was reported recently, good quality, low toxicity profile, good quality of life. Now, what do you do about switching gears, treating the elective pelvic lymph nodes? This is a question for the ages. I don't know what the bias is here, but
the same problem.
yeah, yes. If you ask a room of radiation oncologists who treat prostate cancer, half will raise their hand, half will not. And the studies from RTOG by Mac Roach have had very mixed interpretations, let's just say. Ultimately, RTOG 9413, which tested the use of whole pelvis radiation therapy in high-risk prostate cancer, was in fact a negative study, but those that believe in pelvic radiotherapy will interpret it as also being positive. So it's a very funny subject altogether. But this is an age-old topic, and as I mentioned, in 9413, they used patients who were calculated to have 15% or higher risk of lymph node involvement. Old study, old imaging, not like today's PET, right? So being negative on a CAT scan from 1994 was very different than our clinically node negative patients on PET. But nonetheless, they never showed a significant difference in progression-free survival, which was the primary endpoint. POP-RT by our colleagues at Tata Memorial is the most recent study, took very high-risk patients, over 50% lymph node risk in almost a third of them, used almost entirely PSMA PET, used higher radiation therapy dose, used longer androgen deprivation therapy, used image guidance, and sure enough, whole pelvis radiotherapy improved disease-free survival, suggesting that perhaps modern techniques might actually provide a benefit if you select the patients well and if you use state-of-the-art imaging. We are awaiting the results of RTOG 0924, which is Dr. Roach's latest attempt at looking at whole pelvis radiotherapy. This is now with longer androgen deprivation therapy and prostate dose-escalated radiation therapy, looking, however, at a more favorable risk population, as well as JETUG AFU 23, which is looking at unfavorable high risk. And there's several SBRT whole pelvis studies coming our way. They are looking to explore what is the actual sensitivity of small bowel and questioning maybe perhaps what we have radiobiologically always considered to be our limits. But at the same time, these studies are very daunting because you have to have reproducible positioning, internal motion concerns. And again, if you don't have expertise in this area, it's not something to take lightly when you're delivering such high dose to the abdomen. So we will await those studies. In the meantime, there is a case for radiotherapy in node-positive prostate cancer patients. For the longest time, it was felt systemic therapy. Our medical oncology colleagues are the only ones that should be treating these patients. But we have had various database studies retrospectively suggesting overall survival benefits if you add radiotherapy in these patients. And then, more recently, prospectively, the STAMPEDE study, which specifically had an exploratory analysis of the impact of radiotherapy in just the subset of patients who were clinically node positive. It was 177 patients out of the entire STAMPEDE cohort, and they received radiotherapy, 82% of them whole pelvis radiotherapy. And when they did an analysis in this subcohort alone at the impact of radiotherapy versus no radiotherapy, and remember, they all had what we might consider optimal systemic therapy today, the adjusted hazard ratio was 0.48 with the radiotherapy. And again, compared to 0.35. And so if you look at planned versus received, that also made a difference, again, because it was not required. So again, this is an exploratory analysis only, but for the centers that actually did deliver the radiotherapy, this suggests that we play a role in node-positive patients, and we should not be nihilistic and say that they are not curative. Perhaps in a small group, there is a chance of at least delaying recurrence. What if it's PET-detected node-positive disease? So now just those patients that are very micrometastatic. Or what about patients that have been treated and they come back with disease, but it's only in the nodes and it's fewer than 5, what we call nodal-only oligorecurrence. The state of the art now, first was looked at in oligopelvis, JETUG P07, single-arm phase 2 trial that actually showed the feasibility of doing 6 months androgen deprivation therapy, pelvic radiotherapy, and boost to the PET-positive nodes with a small group, 67 patients, with a median follow-up of just under 50 months. They found 2- and 3-year progression-free survival benefits of 81% and 58%. And again, node-positive patients, this is extremely promising with really relatively low 2-year grade 2 or higher toxicities. And then, most recently, Peace Storm, randomized phase 2 superiority trial, which Dr. Ost and colleagues just reported in the Lancet. This looked at 6 months ADT. This is in the population that's been previously treated and now recurs with just nodal disease, 5 or fewer lesions. And here, patients were all receiving radiotherapy to the metastases or salvage lymph node dissection. So again, this was an option within the study, but here we're focusing on the radiotherapy piece. And the randomization here was, do you treat the rest of the lymph nodes? Should we still treat this patient with a more curative intent rather than just spot treating what we see. And that is a fundamental question we radiation oncologists who treat prostate cancer patients face all the time. Do I just focus on what I see, or do I assume there is more and give this patient the benefit of the doubt? And here, not only was it recently reported no significant difference in acute GU-GI toxicity or quality of life reductions, but also most recently a benefit. Oh, and I'm so sorry, I'm missing that slide. It's not coming up, but most recently now a benefit in metastasis-free survival. So really suggesting to us that there is in fact a role as radiation oncologists to be more comprehensive in these patients. And switching now to post-operative in my last slides, the INDICATE trial, ECOG-ACRIN 8191, is a trial that I am the national chair for. And this is a study where we are looking at patients who have had biochemical recurrence after prostatectomy, who are receiving baseline PET because of biochemical recurrence defined as 0.2 or higher after surgery. And depending on the presence or absence of extrapelvic metastases on PET, we are randomizing them to either systemic therapy intensification or to metastasis-directed local or focal therapy intensification. If there is no evidence of disease outside the pelvis, we know that even after standard salvage therapy, which is radiotherapy to the pelvis and the prostate bed, 6 months of androgen deprivation therapy, and hope for the best, we know that a third of those patients will still go on to have a second biochemical recurrence. And so this study is looking to enhance with 6 months of apalutamide as a representative of androgen receptor pathway inhibitors in general, to see if the addition of apalutamide to standard 6 months ADT improves outcomes in those patients where the disease is felt to be confined. Conversely, if the PET reveals that there is disease outside of the pelvis, they have to be conventional imaging negative. This study is focused solely on patients that would never have been deemed to have metastases were it not for the PET. And remember that traditional staging still requires conventional imaging positivity to be M1. So technically, these patients are M0 from all of our studies thus far, which relied on conventional imaging. But we know in practice, if we get a PET and we see it's positive for metastases, we treat them as if they're metastatic. But do we know that that's the right way to approach them? Do we know that they should be withheld from having curative pelvic treatment? We don't. So the idea here is everyone receives standard of care, salvage prostate bed, pelvic radiotherapy, 6 months ADT. Everyone gets 6 months of enhanced systemic therapy with apalutamide. And the randomization here is to treat those metastases up front versus at a later time if there's disease progression. And this study has already completed accrual for arms A and B with a primary endpoint of progression-free survival, which is a composite endpoint of radiographic progression on standard of care imaging or on PET, symptomatic disease or death, so it's a composite endpoint. And arms C and D are continuing to accrue and will be part of a larger consortium study. So putting it all together, where is this all headed? There's a lot of excitement right now in locally advanced and metastatic patient treatment with more aggressive local treatment if it can be done safely and if it makes sense in the setting of what is ultimately systemic disease. So with our medical oncology colleagues and our surgical oncology colleagues, we have a lot of excitement ahead. And I just want to point out in my final slide, again, the latest in the ASCEND SBRT schema, which we'll be reporting in terms of 5-year progression-free survival, and really looking now at either low-dose rate or high-dose rate boost compared to SBRT boost. So taking all of the slides I showed you thus far and now doing a direct comparison. We have the PRIME trial coming from Dr. Murthy and Tata Memorial. Again, he established the use of whole pelvis as actually being beneficial in modern era, modern imaging trial. So now the question becomes, can we push this to moderate and extreme hypofractionation in clinically node-positive disease? We also have PACE nodes from our colleagues in the UK. Similarly, 5-fraction SBRT, and that will be both looking at prostate alone versus prostate and pelvis. And then biomarker-driven studies, of which I mentioned, indicate, but also Thunder and PREDICT-RT, so that we can increasingly incorporate biomarkers looking at both pathology as well as molecular imaging to better define our patients. So again, thank you. I know that was a whirlwind of just a lot of what's going on in the prostate cancer space, but hopefully that was helpful. And I'm very, very happy to Evaristo, to our gracious host, and all of you for your kindness in having us today. So thank you so much.
Thank you so much.
Happy to take questions.
I will try to change the television.
Yes,
because
of
we have
course.
50 participants.
Oh,
all
yes.
over the
Oh my
group.
goodness, yes.
If there is any question from the virtual audience. Okay.
Go through that again.
Probably very
Dr. Koukourakis, do you have any comment, any question?
Dr. Neha, thank you very much for your excellent presentation. I have actually a short question. Do you
Of course.
believe that in a high selection group of patients with low risk prostate cancer, maybe treating only the tumor without treating the whole prostate or pelvic lymph nodes, maybe we have the same results regarding tumor control and maybe spare better the organ at risk? And
Absolutely.
hmm?
Oh, go ahead, sorry.
And do we have any data regarding the combination of radiation therapy with second-line hormone therapy like Enza or abiraterone in the first-line treatment, concomitant with the radiation?
Right. So I know there are techniques, certainly like high frequency ultrasound, that are being explored, as well as partial radiation and omitting the rest of the prostate. In the US, I will tell you, there are very limited centers that are doing this, and there's not a large effort across the country through our cooperative groups to pursue this, although it makes great sense, like you said, for limited risk patients with very, serious concerns about toxicity. It would make great sense to limit the toxicity and do that. I think the hesitancy has been the question about how to go back and treat. And we have seen some complications from some of those patients who come back with recurrent tumor, either very close to the original site or close to the urethra in the setting of having had the prior high dose, the partial radiotherapy. And I think until we can get to a point where we feel comfortable with our targeting and our ability to really limit the dose in repeat radiation, I think until we get to that point, there will always be a barrier, at least in the United States, where we get very concerned about patient toxicity and bad outcomes, and patients coming back. That's been the limiting factor. I think we are going to see, however, as the hypoflame and other studies come around, people will probably attempt it in the reirradiation setting, but we still are very limited in our partial treatment. Do you do partial treatments here?
No.
Okay, focal, yeah, we don't do
Actually,
focal either.
no.
Yeah, thank you.
Thank you,
Thank you,
George.
thank you very much.
George, is there any other comment from our audience? Okay. Oh, we have some participants from Lucerne. Dr. Mariangela Kaimi, our colleague from Sweden. Here, Andreas.
Hello.
Hello, Andreas. Welcome. So we can move on the
Yes.
second speech now.
Perfect,
Okay.
yes. Let me get that.
If you are ready, John. Yeah, no.
You have to turn on your microphone, please.
Oh, you would have me do that.
Okay. Now is that you can hear me now?
Okay.
Oops. All right. Is that, let's try that. Oop. All right.
Is it better now?
How is
Is
that?
it better? George, is it better? Aris?
Yeah.
Yes,
Thank
much
you.
better.
Sorry for this.
All right. Here we go. Fair enough. And I can see the faces. As I was saying, my area of interest is radiation therapy for hematologic cancer, so mostly lymphomas, but also leukemia, multiple myeloma as well. Currently, Neha and I practice at Penn, which is a multi-center, huge organization. So we have, I think, 16 different centers right now that are all under our own umbrella at Penn. So they range from an hour and a half one direction to an hour in the other direction, an hour another direction. And we have a lot of our patients are being treated in the community. Neha and I both, up until recently, were at the main center, at the Perlman Center. And I recently moved to Penn Presbyterian, where we're building a new Proton Center. And so it's been an opportunity for me to see sort of what life is like in a regional center as opposed to the main hub, where everyone's a deep expert in everything. So now I'm seeing patients where I don't really know what to do most of the time. And I have to look up the guidelines. And so one of the things that has given me, I think, a lot of insight is seeing how to approach these complicated patients through the lens of some set of guidelines and trying to match up a complicated patient and the guidelines. And how do you put those two together? Because the guidelines can help, but they don't always help. And so I want to talk a little bit about how guidelines are developed in an emerging field, which is using radiation together with CAR T cell therapy.
Use your mouse.
I just use the mouse to click. So,
Just what they do.
oh, here we go. It's working. All right, here's my disclosures. Okay, so I want to talk a little bit about the guidelines that we have in general. I want to talk a little bit about the data that are out there, these emerging data, and then sort of how do we ask questions and try to help answer that for the community and for ourselves. So in the world of guidelines, there are many out there. Neha already mentioned the NCCN, National Comprehensive Cancer Network, very US focused. And then there's the European Society for Medical Oncology, which has a lot of very good guidelines, I think. And then for pediatric cancers, Children's Oncology Group. And then there are a sort of a special type of guideline, which are called appropriateness criteria that are put out by the American Radiation Society, used to be from the American College of Radiology. And instead of telling you what to do, they just say, here are some different options. And you say, that's a 9 or that's a 3. And so you would say this is appropriate or not appropriate, but doesn't necessarily tell you exactly what to do, like the NCCN guidelines do. And then the group that I've been working closely with is the International Lymphoma Radiation Oncology Group, or ILROG. And even though lymphoma is in the name, they do deal with all the hematologic cancers. And it's a pretty small group of experts, but it is worldwide. And so it's a fun group to be with. They like to go out to dinner and chat. But one of the things they've done is create some guidelines that are quite specific for radiotherapy in the hematologic cancers. And then more recently, the NRG Hematologic Malignancy Working Group has paired with NRG, used to be RTOG. They never had a lymphoma group in RTOG, but now that NRG is together, they're letting the hematologic cancer people kind of move in there. So we are putting out some select, publications to try to help harmonize at least sort of the understanding of how to talk about radiation for lymphomas. So the ILROG sort of went on a run of putting out guidelines. So in 2014 were the first one. So they did it for non-nodal nodal non-Hodgkin lymphoma, and then Hodgkin lymphoma. And that's where they introduced this concept of involved site radiotherapy. And so this has really taken on a life of its own. This is sort of the standard now. And that was defined back in 2014. 2015, they put out one for skin lymphomas and other extranodal lymphomas, and then pediatric Hodgkin lymphomas. In 2018, after sort of a big meeting in Boston where they brought a bunch of people together, they cranked out several more with more specific topics, including lymphoblastic lymphoma, CNS leukemia, extramedullary leukemia, then TBI, specifically a techniques paper, and then one for plasma cell diseases, which I think is still actually pretty good, and then relapsed refractory Hodgkin and non-Hodgkin lymphomas. And then we did a special one for proton therapy. We thought that it would be helpful to sort of communicate to the world why we thought proton therapy may or may not be a good idea for certain patients with mediastinal lymphomas. And of course, at Penn, as a proton center, all of our patients ask about proton therapy. But if you're coming from a place that doesn't have proton therapy, do you really want to send a patient 2 hours away, 3 hours away? Is it really that much better? And so we want some guidance around that. So that's a pretty good document. And then in 2019, there's one out for imaging. So how do you incorporate PET CT in particular, but also MRI to a lesser extent in the planning of lymphomas. And then in 2020, we did what we call like a mini atlas. So there's just a bunch of cases on there, and how do we contour them? So we had sort of a consensus of actually putting contours. So it's really just an appendix. So I'm not sure how helpful it is, but it was a lot of fun putting it together because we argued a lot about what the contour should be, because that's where, for radiation, where the rubber meets the road, getting down to those fine details. And do we actually do things the same way, and try to put that in a way that hopefully can be useful. So 2020 is the last time they put out a guideline. It's 2025. All of these guidelines are kind of getting a little bit old. The NCCN puts out guidelines like every, I don't know, it's like 6 months. So these are old, and so they are dated. and the ILROG has not developed a mechanism for updating them. So they need to, but also there's some topics that will need to be addressed, as we'll discuss in a minute here. So just by show of hands, how many people are familiar with CAR T-cell therapy? All right, so I will. No, that's fine. Yeah, so so CAR T-cell therapy, it stands for chimeric antigen receptor. Yeah, it's just the car in my head. But the idea is that you take out someone's own immune cells, so the lymphocytes. So you take them out of the body, and then you put in certain genes that will help recognize a cancer cell and also make the T cell ready to kill. And then they are grown up in the lab and then injected back into the person. Now, that whole process takes a while between doing the genetic engineering, the growing. And so it's about, well, now it's about 3 weeks. It used to be 4, maybe 5 weeks. And it's a really amazing technology. And one of the CAR T-cell therapies was actually invented at Penn by our colleague, Carl June. But there's other places that were onto the same technology at around the same time. And so this is really an amazing technology. So it's taking the immune system that forgot how to kill the cancer cell, and it reminds it how to do it. And we've had really, I would say, miraculous results with CAR T-cell therapy. And I don't say that lightly. Obviously, it doesn't work in everybody, but it has literally cured people who had no other treatment options. So truly a miracle from the lab. Oh, so the first FDA approval for CAR T-cell therapy was for acute lymphoblastic leukemia, and the type of CAR T-cell was the one that was invented at Penn. The brand name is Kymriah. This has this very long name that everyone just calls it Tisa-cel. Shortly thereafter, one of the competitors got an FDA approval for aggressive B-cell lymphomas, and that one's called Axi-cel. So really in 2017, commercial use of CAR T-cell therapy was out there. Thereafter, several more indications for other hematologic cancers, but this sort of was the FDA approval. I will tell you that in the years before that, we were treating patients with CAR T-cell therapy on trial. And my colleague, Steve Schuster, who is an amazing medical oncologist, loves lymphoma. It's his life's passion. He's a sort of like a crazy professor. He's always, thinking of crazy ideas, but he loves to call me into his clinic rooms to help see patients. So one day, this is right when we're starting the clinical trials for using CAR T-cell therapy to treat relapsed refractory non-Hodgkin lymphoma, calls me up, saying, "John, come to room 17. I think I was like 10 minutes away from having to go pick up the kids. So I had to rearrange something. Neha probably picked up the kids. I went there, and Dr. Schuster had this patient in front of him who had just gotten off the plane from Germany with a lymphoma in her chest that was pushing on her. Oh, I didn't do anything. Oh, it was pushing on her breathing tube. And she was a little bit short of breath, and she was out of options. She had gone through everything. So she flew to Philadelphia specifically for this clinical trial. And we knew that it was going to take weeks to get those cells made. And this tumor was probably going to kill her if we didn't do something sooner. So she got her cells collected, and then it was 3 weeks of just waiting around in Philadelphia. So Steve said, "John, can you radiate this spot to try to just keep everything in check while we make the cells?" I said, "Sure, why not?" And so we got her on treatment. Her tumor shrank beautifully. Her breathing got better. She got the CAR T cell, and she was well at that point. And in fact, that was the only site of disease she had. There was nothing else. So we didn't really know if the CAR T cells did anything. It could have just been the radiation, but she did great. So after that patient, Dr. Schuster would keep sending me patients who needed some treatment during that time. So this sort of started this concept of using bridging radiation. Now, if someone says, how do you use bridging radiation during that manufacture period? What's the answer? It's very hard to describe that. And I will point out that this field is moving so fast. This is a bibliographic study looking at CAR T-cell therapy in publications. And I'll point out that the end date here was 5 years ago, but there's this massive explosion in sort of scientific literature around CAR T-cell therapy. So how do you even keep up with this? You know, we did comment in 2018 about using bridging radiation at the ASTRO meeting. The first publication was from the group from Moffitt in 2019, where they published just on a limited series of, I think it was like 10 patients, where they used bridging radiation. But finally, we were able to kind of pull as many centers together as we could. So we have 10 centers in the US, and we just published this consortium report just a couple months ago in Blood Advances. So very exciting for our trainee, Dr. Yeger Rahman, who now is on our faculty at Penn. He's a very good doctor. But we are now just starting to get some data on a very quickly moving field. And so just to kind of put this in a timeline of, you know, if you're trying to tell someone how to use radiation together with this brand new technology, we found it helpful to kind of break it up into parts. Okay, what exactly are we talking about? Because if someone has a progressive cancer, relapse refractory lymphoma, you know, even before they meet someone who's an expert in CAR T-cell therapy, they might need radiation just to help with some symptom or other systemic therapy, just to kind of get them to the point where they can meet with one of those experts. Now, you've seen the expert, they're thinking about it. And in the US, to get CAR T-cell therapy, there's this huge insurance process. So you have to apply, your insurance company has to say, maybe send me more medical records, because it's a very expensive treatment. So they are, you know, quite resistant to pay for it. So they have to consider it. So there's a long time then before you can actually start the process. Now, once you've got all the approvals and everyone decides it's a good idea, and you remove those cells, that's sort of where we found the most use of radiation in this bridging setting while the cells are being manufactured. Now, they can do other chemotherapies or other systemic therapies during that time, but you know, this is the place where we thought radiation has actually been the most useful. Then the CAR T cells infused again. Well, what if it doesn't work? What if you treat someone with CAR T cell therapy and there's 1 or 2 spots that shrunk halfway, but not all the way? Will radiation to that spot help? Who knows? Maybe. It's an interesting idea. And so we call that salvage or consolidative radiation. So some of the first questions that came up when we started doing this was, would the radiation cause some toxicities or side effects that would keep them from getting the CAR T cell therapy? So that was question number 1. And I will say that I think that that question has been answered. There's enough papers out there right now. I think people are comfortable with it. Now, is there any impact of using radiation on the important outcomes, so progression-free survival or overall survival? It's an open question. And then the timing. I alluded to this already, but if you're using a radiation, it's not just at these different steps along the way, but how many days is safe? You know, if you do CAR T cell therapy and you want to do radiation afterwards, how long do you need to wait? Is it 30 days, 60 days, 90 days? If you're doing bridging radiation and they're ready for the cells, do you have to wait 4 days, 5 days, 2 weeks? There's a lot of detailed questions that we don't know the answers to. And then as radiation oncologists, we control 2 things, dose and volume, right? So the volume question is, do you treat just the spots that you can see, or do you treat elective nodes around? Age-old question, as is the case with prostate cancer. And then, of course, dose and fractionation. One of the things that we found is that when you're asked to see these patients, oh, the cells are being made, they have pain. Someone says, can you see this patient? Well, starting radiation takes time. I mean, I don't know what your time is from consultation to start treatment, but a couple of weeks, 3 weeks, more?
Here in this department, no, it's shorter.
You're fast.
We're fast, yes.
But you want to get moving.
Yes.
And you might not have more than 2 or 3 weeks. So
Yes.
instead of treating for 4 weeks, we're treating in 3 or 2 weeks, sometimes 1 week, just because you're they're ready for the cells, and you don't want the radiation to slow down the process. And then, the other question is, how do you use imaging? So how do you use lymphoma, particular PET-CT, with respect to bridging radiation? So the one guideline that the ILROG did put out that I thought was helpful with answering this question of how fast can we compress the treatments was the guideline that was put out during the COVID times. And so they did, what were standard dose and fractionation treatments. And they said, well, here's a shorter fraction. So we've been using this pretty frequently to try to compress a radiation course. So again, not a lot of data are out there, but there are some data that are emerging. And there's a few multi-center studies using commercial CAR T-cell therapy and radiation that are worth knowing about. So this was a study published by the UK group where they essentially had 12 UK centers, but they are all sort of connected together because they would decide who would get CAR T-cell therapy. So in the US, it's the insurance companies. In the UK, it was this sort of this panel, this multidisciplinary panel. And because radiation oncologists were there as part of the process, they would always raise their hand and say, well, I can radiate that. And interestingly, nearly a quarter of the patients who were getting CAR T-cell therapy actually had radiation therapy as well. A third of those patients in that group actually treated all of the known disease. So we call that comprehensive bridging radiation. And, their findings were sort of interesting because what they showed is that they did not really get into the way. So what we call the vein to vein time was not slowed down. They didn't interfere with the administration of CAR T-cell therapy. And interestingly, over time, the amount of radiation therapy that was used went up. They did have some patients who had radiation related toxicities, grade 3 and higher, but essentially a very small number. So just a summary of the UK experience. So about a quarter of the patients were getting bridging radiation. They were able to use sort of advanced techniques such as IMRT in 2/3 of those patients. So they really, had the team work fast and hard for those patients. They didn't delay the CAR T-cell delivery, and they did sort of settle on a few common fractionation regimens. So 30 gray and 10 fractions or 20 gray and 5 fractions were the most commonly used regimens. And then the actual toxicities from the CAR T-cell therapy were not any different who got radiation versus who didn't, which is an important sort of safety factor. So the Mayo Clinic, they are 3 centers. So there's one in upstate New York, one in Arizona, and one in Florida. But they pool their data together, and they have a lot of patients come through because it's Mayo Clinic, right? Everyone sort of Mayo Clinic. So they were able to just put Mayo Clinic data together, and a very talented resident now, he's going to become an attending at MD Anderson, Omran Saifi. He really studied their patients, and they published some really nice papers on what their experience was. And the one thing that I thought was the most interesting from the Mayo group is this use of consolidated radiotherapy for those folks who had a PET scan at 30 days after the CAR T-cell therapy, and they radiated the residual disease. So they're the ones that kind of threw it out there that this might be interesting. So again, this is not randomized. This is just all retrospective. But the patients who had a positive PET at the 30-day mark, if they had consolidated radiation therapy, is this red line, they had improved progression-free survival compared to those who just were observed. And again, at Penn, we usually do a 60-day PET. So this 30-day PET was a little early, but a very intriguing idea of trying to make that CAR T-cell work better. And if you have a spot that's not going to respond, zapping it, and those patients may actually have a long-term survival. The Mayo group also looked at some of this question of what is like oligo progression or oligo resistance. So they looked at just the patients who had 5 or fewer sites of radiation, sites of persistent disease. And when you use comprehensive bridging radiation versus no bridging radiation, we saw that more of those patients had improved progression-free survival when you didn't use bridging radiation. So the number of sites is how many is too many? We don't really know the answer to that, but it's probably around 3 to 5, right, of how many sites you can go after. So the US ILROG consortium of 10 centers was something that was actually born in COVID. I was on a sabbatical that summer, and we started doing all these like web meetings with people who are interested in this topic. And so we would have a little seminar, and then people would talk about what to do and what are you doing here, what are you doing there. And it really started this consortium where we were able to get data from 10 different centers and put all those data together. So this was a really exciting time during some really upsetting times, to be honest. But we recently published this consortium experience, 172 patients from 10 different centers. And interestingly, of those patients, 39% had this comprehensive bridging radiation where all the spots were treated. So that's a theme that is starting to emerge, is if you treat all the spots, those patients seem to do better. One of the things that was rough about this study is because it was from 10 different centers, we had a billion different, well, not a billion, it was actually 44 different dose and fractionation regimens that people just tried because no one knew. They were just making things up on their own. And so we saw all these different fractionation regimens in this series, which was kind of interesting. A couple of them were using very low doses, which is this idea of like, can radiation sort of prime and make the cells go in there? So rather than trying to use the radiation to kill every last cell, just to try to wake it up immunologically, there's a little bit of that going on. Again, most people settled on 30 and 10 or 20 and 5, but again, it was all over the place. So one of the things that we, of course, want to understand is, was there any issues with worse toxicity with the typical CAR T cell toxicity? And the answer is that we didn't really see anything that was concerning, which was good news. And then we also looked at patterns of failure. So places where we treated versus didn't treat, and the majority of the recurrences were out of field, which again sort of makes you think that more comprehensive radiation is probably a better idea. And then one of the other things that we looked at was during that bridging period with radiation, if people were getting better, we found out that they were going to do better in general. And so we used the LDH sort of before and after, and we saw if radiation basically normalized your LDH, then those patients did better than those patients who either had a high LDH that didn't get better or went from normal to worse. So these patients all did better than these patients, which kind of makes sense, but it does give you an indication potentially of, does someone need more before you put a very expensive CAR T cell therapy into their system. So this is a very big table, but I want to just kind of show you this, that there's a lot in this paper. But again, people who had comprehensive bridging radiation actually had a lower incidence of progression compared to those who had just bridging radiation to a limited number of sites, which again makes us think that trying to be aggressive about treating all the sites is probably a good idea if you can pull it off. So as we were collecting all those data, of course, the world of CAR T cell therapy was moving, and some very important studies were presented, which showed that CAR T cell therapy is actually beneficial, not just in patients who have had 3, 4, 5 lines of treatment, but those who are in their first relapse. So they get their first standard chemotherapy. If they relapse, doing CAR T cell right away is actually beneficial. So we started seeing more and more of those patients who had what we call second line CAR T cell therapy. And interestingly, nearly 40% of them in our experience at Penn were treated with bridging radiation. So you can see this evolution over time where we're using more and more radiation as part of CAR T cell therapy. Just a couple of other interesting things that are out there that we're trying to figure out how to digest, which is if you have brain-only disease. So can you use stereotactic radiosurgery for bridging for patients who have parenchymal brain disease? We published this three patient series. I don't know if it's a great idea, but it's something to think about. One of the patients had a lot of radionecrosis. Yeah, but it's you have to use what tools you can in different situations. So the questions that we have now are sort of also thinking about, can you make CAR T-cell therapy safer? So we do know that the more lymphoma you have when you get CAR T-cell, the higher the chance of having these terrible toxicities, so cytokine release syndrome and this neurocognitive problem. And so if you can maybe decrease the number of cells and sort of debulking, can you make the CAR T-cell safer? We don't know. And then this other idea of, can you use very low doses of radiation, 4 gray, 8 gray, just to wake up those sites of lymphoma to get the CAR T cells to infiltrate. We have seen in the lab that if you radiate with 2 gray times 2, then you actually see more CAR T cells traffic to those tumors. So it's an interesting idea. And we know if you only are using 4 gray, you can treat 8, 9 sites. I mean, it depends on how much time you have on your linear accelerator. It sounds like you guys don't have a lot of time. And then this idea of using combined modality therapy. So we have thought about in the world of Hodgkin lymphoma and non-Hodgkin lymphoma that if you do some chemo and some radiation, maybe you have better outcomes with less toxicity. The same concept may also apply to CAR T-cell therapy. And then the number of sites can you go after? Is it 5? Is it 7? Is it 3? We still need to answer this question before we can really say in any kind of guideline. We talked a little bit about CNS lymphoma, and then how to use biomarkers. So if the PET scan is getting better or the LDH is getting better, what does that mean versus if it's getting worse? What does that mean? And how do you do sort of response adapted treatments? So the ILRUG guidelines and relapse refractory diffuse large B-cell lymphoma don't mention CAR T-cell therapy at all. So there's really nothing out there from the ILRUG. There's a little bit from the NCCN where they say you can use bridging radiation with CAR T-cell therapy, and they kind of give these wide ranges, 20 to 40 gray. So it's something that's out there. It would be covered by insurance in the US if you say we want to use bridging radiation because it is in the NCCN guidelines. There is a paper out there that the Mayo Group put out, this sort of consensus, which I think is a good first step. But we are hoping to kind of, illuminate that a little bit more. And because right now at this hospital, are you giving CAR T-cell therapy for patients? And they did. Okay. So our experience is that, what happens is centers start to use the CAR T-cell therapy and they get good at that. And then at some point, everyone wants to use bispecific antibodies. So does everyone know what bispecific antibodies are? Mm-hmm. All right. This guy does. Mm-hmm. So this is the next thing. So they've developed little molecules, so antibodies that on one hand will grab onto the cancer cell, on the other hand will grab onto the T cell, and it brings them together. And it's like CAR T-cell therapy in a bottle. You don't have to take out cells, it's less complicated. And they are developing these for a lot of different types of tumors. And there's several that are already FDA approved, including for non-heme malignancies, including lung cancer. So these are going to be coming out. And the question is, well, how do you use radiation with them? Can you use radiation with them? So one of the jobs that I used to have, I used to be a chair of one of our ethics boards. We call the Institutional Review Board, or IRB. And these bispecific antibodies were being tested while I was the chair. And I remember very distinctly, we had a study that had to be put on hold because a couple patients died. And the FDA halted the study and they said, you're killing too many patients. So what they end up having to do is, instead of giving the full dose right away, they give these little tiny doses. So to give bispecific antibodies, you have to do what's called a priming dose. And we keep our patients in a hospital for like a week. So you start with a little bitty dose, do another dose, and another dose. And it takes about a month, and maybe 3-4 weeks to get to effective doses. So during that month, what can be useful? Radiation. So we've been using radiation to kind of do these bridging while you're doing this ramping up of the bispecific antibodies. So right now we're doing this in lymphoma, but I think this is going to start happening in other types of cancers, lung cancer, et cetera, as we see bispecifics. So it's a very rapidly changing field, and thinking how to use radiation to integrate with that. And again, how do you make a guideline? I have no idea. So I will tell you, this is I think my last slide. This gentleman, his name is Brandon Imber. He's a junior faculty at Memorial Sloan Kettering. He is been charged to kind of organize the ILROG group to write a guideline for CAR T cell therapy. And we told Brandon we want him to have this done by the end of 2025. He just had a second baby, his wife did, so we could give him we gave him a few months break. But there's a really important project for ILROG. So hopefully we'll have something that the global community can use when we're thinking about how to integrate radiation with these immune therapies. All right, well, thank you guys, and thank you for having us. Really appreciate it.
Thank you so much, both of you, for sharing all this great expertise with us, with the University of Crete and also the Greek Society of Radiology. Maybe we can see the participants.
Oh yeah, do you want me to?
No, maybe we can see also from your computer.
Yeah, from Zoom.
If you
Just stop
close
sharing.
your presentation. Okay.
So maybe stop sharing.
I would like.
Here we go.
Hey.
Oh, there's a hand.
We can see all lines. Yes.
Yes. Thank you, both of you, for the excellent presentations. We're actually using bispecific antibodies in medical oncology now in small cell lung cancer. There's a new bispecific antibody called darlatamab, and we do that priming effect using a small dose and then a bigger dose and a bigger dose to avoid the extra toxicity. But I have a question regarding the consolidation RT. There is a theoretical risk of killing of the remaining CAR T cells that have infiltrated into the tumor if they still have some activity in the residual mass. If you give consolidation RT, you're killing them off. You don't have that disadvantage in the bridging radiotherapy. But the consolidation, we know that T cells stay around for a while. So you probably need that extra effect. If there is a.
Yeah, it's the
Okay.
Okay, we apologize for this.
All right, yeah, so the question is essentially if you have CAR T cells in the tumor and then you zap them, you're going to kill those lymphocytes off. So I would say we have equipoise to answer that question. It's not obviously a good idea or a bad idea. I think the counter argument is, well, you zap those cells, but hopefully there's circulating CAR T cells that can rehome back to that area. I don't know the answer. I actually would love to see a randomized study of consolidated radiation for day 30 positive PET to doing something like a bispecific versus radiation. I think that the ECOG is considering such studies, but we probably won't get a radiation arm in there unless we work very hard.
Do we know if CAR T cells are as sensitive to radiotherapy as the native cells?
I don't know if we've ever done the experiment.
Yeah.
Lymphocytes are so sensitive to radiation. I mean, 50 centigrade will kill lymphocytes. And there's no particular reason to think that an activated lymphocyte would be any less sensitive. So I feel like someone should have done the experiments at some point, but I don't know if it's been.
When we designed our PSMA CAR T for prostate cancer,
that was the concern in the protocol that Carl June had working with him, was he didn't want to do any exposure to RT, because again, I think in the lab, certainly the experience has been that they are just as sensitive. So the timing of the radiation is always key. But again, for heme, I think it's a little different than for us in the solid malignancies. And I think there was a question at one point about, can we add a plus minus consolidated RT arm afterwards to see what the impact is, and then do measurements. Because it's PSMA CAR-T, we don't even have to do anything, just image and see what we could find, was the thought, but we haven't done that yet.
You also use CAR-T cells in solid tumors?
So prostate is
Yeah, so the
brain.
CAR T cell story in solid tumors has been more mixed. So we have a lot that have been tried. So we had one for glioblastoma multiforme. So
That was just
it was
reported.
targeting the EGFR B3 mutation. We have one for prostate cancer, so PSMA CAR T cell. And the initial attempts showed that the CAR T cells just weren't as effective as they were in the heme malignancies. And so what they did is they re-engineered the CAR T cells around to have some extra oomph. So they call this an armored CAR.
Yeah.
And so one of the concepts is to use a dominant negative to try to like sort of take down the tumor cells immune resistance mechanism. So there's a TNF, a dominant negative,
TNF, yeah.
and then there's an IL-17 armored CAR T cell for heme malignancies. Right. That's the one that Jacob Sabota just reported on.
So that they're extra kind of power, yeah.
So I think we're going to get there, but I think it's a slow road. The bispecifics may beat the CAR T cells out in the solid cancers, is my guess, to be honest, because I think they're just faster to test and less expensive.
Also, lung cancer is the closest example to hematologic
Yeah,
malignancy because of the kidney phase.
Yeah.
Right.
We have a question from Professor John Georgakopoulos. John Georgakopoulos is another John. He's a professor in Faculty of Medicine, University of Athens. He's in the University Hospital of Heraklion. He has the experience also with the CyberKnife. Dr. Georgakopoulos, yes, we can hear you.
Okay, Kalispera from Athens. Thank you both for your excellent presentations. I want to congratulate Professors Gelaki Mavroudis and of course Maria Tolia for organizing this webinar. I have a question for Professor Plastaras. From your experience, are you aware of any trial testing the combination of radiotherapy with T-cells lymphomas like MF or Sézary syndrome, because you know better than me that they are a special entity which regresses, refractory disease. Are you aware of any trials testing the combination of radiotherapy with T-CAR cells in MF?
You treat a lot of MF.
No, well, I do, but I think in terms of, is there a CAR T cell for cutaneous T cell lymphoma like mycosis fungoides? So Stefan Barta was, trying to get a study. I don't think that it's been activated yet. I think there's a product out there that might have some promise. I don't think there are any data that I know of that have tested CAR T cell in mycosis fungoides, but there are CD30 targeted CAR that they've tried in Hodgkin lymphoma. So there's things that are out there. They just haven't, I think, clicked yet, and I don't think the data are there in those diseases. Although I have to say for mycosis fungoides, we use total skin electron beam radiation for the cutaneous T cell lymphoma patients, and it's difficult to do. It's a lot of work on the part of the therapist and the physicist, but the patients get such a good benefit out of it. And we've been using the low dose total skin, so the 12 gray, and it's great. will get relief, but it doesn't last very long. So one of the studies that we're working on with some of the pharmaceutical partners is to try to get a sensitizer added to total skin to try to get more out of that 12 gray, because it's very well tolerated, but I think that we could maybe get a few more months if we add in a radiation sensitizer. So that's one of the exciting projects that we're hoping to launch if we can get the money to do it. So
Thank you very much. Thank you very much.
Thank you very much. We have another guest from Jordania, so from Jordan. Is a Dr. Haitham Saraira that is connected also. And another colleague of Mirsini Ioannidou. She is from Massachusetts, from Boston. Yes, from Proton Center. Yes. So we would like to thank you all of you. We have an honorary present for both of you. One Professor Mavrodis, you can give one to the John.
It's beautiful.
Thank you so much.
Yes. Like it so much.
Yes.
Beautiful.
really very nice.
No. The idea was also.
Thank you.
We would like to show you the two.
Yeah, we should show. Yes, thank you.
Okay. Okay. The two plaquettes.
Beautiful. Thank you. Thank you so much.
Thank you so much, all of you.
Yes.
The University Hospital of Crete and the Greek Society of Radiation Oncology. And also there is a connected the Society of Personal of Radiation Oncology. The president is Fondas Vakalis. Thank you, all of you.
Thank you. Congratulations.
Thank you.
Thank you so much.
Thank you. Congratulations.
Maybe see some of you at ASTRO.